Hi, this is Mohammed Ehsan Zafar. I'm the Medical Director for Pulmonary Rehab at UC Health. In this small video, we will learn about acute dyspnea. And this module is specifically designed for cardiopulmonary rehab staff. By the end of this module, you should be able to list 5 life-threatening reasons for acute dyspnea. Identify features in patient history, symptoms, or exam that are red flags for emergency. And list the action steps that you can take once you have identified someone with acute dyspnea in the setting of cardiopulmonary rehab. Dyspnea is a feeling of being short of breath. It is one of the most common symptoms among the adults. Now, it is important to figure out what dyspnea are we talking about in this module. We are talking about acute dyspnea, which means something that is new in onset and is out of proportion for the person's normal routine. As we deal with patients who have chronic lung disease and heart diseases, they will have dyspnea as a routine symptom probably every day. And sometimes one day might be worse than the other, so they will have some day-to-day variation. But what we are covering in this module is acute dyspnea, which would be something that is out of proportion for their normal routine, or something that is totally new for them which they had not experienced before. So what we need to distinguish between when we are assessing a patient is what is a minor self-resolving problem, which is part of their routine symptoms, and what is a medical emergency, because our actions will be different. And of course, our patients will not say that they have dyspnea. They will say something like this, that I'm unable to catch my breath, I cannot get enough air, or I cannot complete my sentence in a single breath, or something of those lines. Sometimes our patients do not like to complain, but we can see that they are more dyspneic than usual. So part of it could be their complaints, and part of it is just vigilance and our exam. How does dyspnea happen? So dyspnea is a complex symptom. It involves our brain, our heart, our lungs, and other parts of the body that contribute to this feeling of being short of breath and prompting the body to take more breaths. So the strongest stimulus to be dyspneic or have shortness of breath is if someone has low oxygen levels in the blood. So hypoxia is one mechanism. And of course, we will talk about in the next slides, there are multiple things that can cause hypoxia. Second, it could be that the lungs are doing a good job in delivering the oxygen, but the oxygen in the blood is not being delivered appropriately. So the oxygen carrying capacity of the blood is diminished. This is in cases of severe anemia, or if your heart function is not robust enough that you have good circulation going on. So poor oxygen delivery is the second mechanism. Then hypercapnia, which means buildup of carbon dioxide in the blood. This happens in diseases in which patients are not able to exhale out the carbon dioxide, such as COPD, severe asthma exacerbations, or neuromuscular diseases where there is a lot of weakness of respiratory muscles. And lastly, dyspnea can also happen if there is too much acid buildup in the body. Of course, with acid buildup, our pH in the blood is lower, and that is a stimulus for our brain to stimulate more breathing and breathe out the carbon dioxide. So any reason for acid buildup, such as lactic acidosis or ketoacidosis, would also make a patient dyspneic. So our approach to dyspnea could be under these umbrellas of pathological mechanisms. That is it hypoxia related, hypercapnia related, is it acidosis I'm dealing with, poor oxygen delivery, or something else. But this way is a bit difficult to remember and difficult to connect to our patient evaluation that we are doing at the bedside. Now, important for us is to figure out what is life-threatening dyspnea and what do we need to do in a setting of cardiopulmonary rehab. So let's look at dyspnea in a slightly different way and try to understand it. This is probably a better way and easier way to understand dyspnea. So let's start from the top. People can have the sensation of shortness of breath or needing to breathe more because of increased stimulation coming from the brain. Our brain controls our breathing mechanism, and there are two parts of the brain. There is a conscious control and a subconscious control. Subconscious control is what drives our breathing when we are not paying attention to it, But conscious control can also be activated in conditions like pain or psychogenic issues. So if a person is in pain, they may be more short of breath. If they have acid buildup in the body or have less oxygen, less carbon dioxide, our brain gets stimulated and triggers our body to have more respiratory rate and take deeper breaths. Then coming to our respiratory system, let's break it down into pieces and say, well, there are causes of main airways, which means the trachea, the windpipe, and its early branches as it branches into the lung. Now there could be some obstruction over there could be inflammation or a lot of secretions. Similarly, we then go down to our smaller airways, which branch off in our lungs and then end up in our air sacs as they are shown over here. In the smaller airways, there could also be obstruction, constriction such as asthma or COPD, or inflammation and secretions that can cause us to be more short of breath. Within the lung parenchyma, which means the air sacs and the interstitium between the air sacs, the blood vessels, the smaller capillaries, and all the lung tissue, there could be inflammation, edema, or flare-up of existing ILD or some disease like that that can make us short of breath. Then we also have the pleural space, the space outside the lung in the chest cavity. So this space is inside the ribs and above the diaphragm but is outside the lungs. So the pleural space can be occupied by fluid like effusion or air in the case of pneumothorax and make us short of breath. Within the air sacs, as I mentioned, that if the blood circulation is compromised, such as in heart failure or any shock where enough blood is not coming to the lungs, or the blood is coming but the blood itself does not have enough oxygen carrying capacity, which means severe anemia and the hemoglobin is not there or it is dysfunctional, this will also make us short of breath. Our dyspnea can also be originated from these major blood vessels that supply blood to the lungs. So in the case of a blood clot that blocks a part of the blood vessel or a part of the lung, such as a pulmonary embolism, can cause dyspnea. A worsening pulmonary hypertension can also cause dyspnea. Then we have our heart, which can result in dyspnea if there is an ongoing angina or infarction in the heart, if the heart is having abnormal rhythm and not able to send enough amount of blood to the lungs, or the pump is failing, which is in a setting of heart failure that you end up being short of breath. And lastly, we should not forget the chest wall. Our breathing mechanism includes this chest wall, which is made of the ribs, the muscles between the ribs, our diaphragm, and accessory breathing muscles that can support our rib cage and help us breathe. In a case of a fracture or pain or some neuromuscular weakness, this can also make us get short of breath. So what we have done is, now as we are looking at a patient, we should start thinking of the anatomy. Start thinking of, is this an upper airway issue? Is this a smaller airway issue? Is this lung tissue problem? Is it a blood vessel problem? Is it a heart problem? Or some problem outside the lungs or with the chest wall? Or is it just some pain, acidosis, or something in the brain? Now, of course, in a setting of pulmonary rehab or cardiac rehab, we cannot figure out the exact answer. But as we are approaching the patient's symptoms and getting information from their vitals and their exam, we can start thinking of which category I'm dealing with over here. Putting names to certain diseases of the same systems, we can see upper airways could be a tracheitis, an infection of the trachea. Upper respiratory tract infections, angioedema, where there's swelling and allergic swelling of the airways that can cause obstruction of the airways and patient can become short of breath. There could be a growth or a lesion, but of course that would not happen all of a sudden. It would probably take some time. In cases of blood vessels, it could be a PE or pulmonary hypertension. In case of the heart, it could be cardiac MI, CHF flare, or an arrhythmia. And similarly for chest wall, it could be a fracture or neuromuscular diseases. For the smaller airways of the lungs, it could be COPD exacerbation or asthma exacerbation that we are dealing with. In the lung tissue, it could be pneumonia, it could be pulmonary edema, which is fluid in the lungs, or it could be an ILD flare. A lot of patients have ILD who come to our pulmonary rehab program. And outside the lung, there could be a pleural effusion or a pneumothorax. And for the blood vessels, it could be anemia that decreases the amount of hemoglobin in the blood, or something like carbon dioxide poisoning that makes the hemoglobin dysfunctional. Now, some of these could be life-threatening. A sepsis, which is a systematic infection in the whole body, can make us have more acid buildup and make us breathe faster. Angioedema, the swelling of the lips, the tongues, or upper part of the airways, can be life-threatening if the swelling expands to the point that the patient stops breathing. PEs, a change in pulmonary hypertension, cardiac events, a pneumonia, COPD or asthma exacerbation, or a pneumothorax. So some of these could be life-threatening. Now again, there's a huge spectrum of how sick the patient is. Each of these diseases could make them a little bit sick or could be totally life-threatening and needs intervention right away. So we need some kind of a assessment to figure that out. This is a heavy slide, but I think this gives us an idea of how to go about this evaluation in our setting of rehab. First is an eyeball test. And your eyeballs get better the more you do this and the more experience you have. So basically, how does the patient look when you see the patient? Is the patient in distress? Or is the patient relaxed and not showing any signs of distress at all? This makes a big difference. This tells you how severe the problem is. Is the patient even unable to talk, utter a few words because they are so short of breath? Are they pale, sweaty, or confused, or dizzy? So these are symptoms that on a quick eyeball exam, you can know how quickly to escalate the problem. So if they pass the eyeball test and you figure out that you don't need to call a rapid response or don't have to call 911 or your physician right away, then you have time to do focused history and focused physical exam. In the focused history, you can ask questions like, when did the symptom start? What are the triggers for it? What other symptoms they have other than being short of breath? Do they have fever? Do they have any sputum production that is different than their usual? So these symptoms can suggest a pneumonia or a flare-up or an exacerbation. Do they have chest pain with it, which could suggest something like a pneumothorax or a cardiac MI? Are they feeling dizzy, which could suggest that their oxygen delivery to the brain is being compromised? Do they have leg swelling that is new, which could be in cases of heart failure or a clot in the leg? Have they gained weight? Are they bleeding? Have they been passing out? So these are symptoms that you can talk to them about. Also ask them, have they been using their rescue medicines and are they working or not? Maybe they're just out of medicines and out of breath, or they're out of oxygen at home. So you can also ask them, have this happened before? And you can review their past medical history, such as do they have heart disease? Do they have history of blood clots? And so on and so forth. In your focused exam, what you need is a good set of vitals. What's their heart rate, respiratory rate, oxygen saturation, and how much supplemental oxygen they're needing right now. So if at home they're using 3 liters and you have gone up to 4, probably not a big deal, right? But if someone does not use oxygen at home at all and now you're requiring 5 liters of oxygen, this is a big problem. This is something that you need to escalate fast. Then look at their temperature, their blood pressure, their weight, and compare those things to the past. In your lung exams, what you're looking for is, do they have clear breath sounds? Are they wheezing? Do they have silent chest? So at a certain point when asthma or COPD becomes so severe that they don't have much air movement and they can have silent chest. And then if you have any crackle, a wheezing sound would be something like so these are the sounds that means there is airway obstruction. And crackles would be something if you take your hair on the side of your head and just above your ear and basically rub your fingers on your hair, the sound that you hear would be the one that you can listen when there's crackles. And crackles would mean something is filling up the lungs with fluid or with infection, so a pneumonia or pulmonary edema. Then you should also look at their mouth and their upper airway to see if there's any swelling, any edema, any redness there, such as angioedema or any upper respiratory tract infections. You can look at their legs and see if they have any edema in the legs. Also, when you're looking at their heart rate, see if the heart rate is regular or irregular. Now, as you're gathering this information, you're also making decision in your head simultaneously. You're looking for red flags. You're looking for ideas to suggest, is this a life-threatening problem, or is this something that is simple and I have time to evaluate more or reevaluate in some times. And again, while you're doing your decision making, if the patient needs it, give them supplemental oxygen if their saturations are low. So try to keep them safe. You can consider putting them on telemonitoring if they are stable and have time. Otherwise, better would be to take them to a place where a better care could be provided. And also you can contact your on-call physician and discuss the case, and that is something that I would highly recommend to do, because sometimes we need help to make the right decision, and you should always feel as a staff member in the rehab that you have help available and you can call a physician anytime. Then your decisions that you have to make eventually are, is this something that I just need to ask the patient to take some rest because maybe they were just exercising or they just came back after walking from the parking lot? Give them some time to rest, give them some water, give them some oxygen, whatever they need, and reassess in a short time and see if they have improved or they are same or they got worse, and then make another decision at that time. Now, sometimes if the symptoms are just mild, and there's no red flags and the patient feels like they can still continue with exercise, then you may allow them to do a milder version of their exercise but have close monitoring for it. Another decision you could make is that the patient is not steady enough for an exercise but not sick enough that they need to go to the ED. In that case, you send them home, but I would suggest notify the physician on call and also notify the primary care physician or the referring physician of that patient. Also tell the patient, give them instructions that they need to call their provider or come to the ED if they get worse. Next step would be if the patient is sick enough or something is totally new for that patient, such as new oxygen requirement, chest pain, or a very high or very low blood pressure, something like that, that should trigger a decision to take them to the ED. And lastly, if something is very life-threatening in front of your eyes and you need help right there and then don't hesitate to call 911 or rapid response based on wherever you're practicing. For any of these decisions you make, I think it is a good gesture and a courtesy that we let the referring physician or the primary care physician know by some way of communication through Epic or by a phone call and tell them that the patient had these symptoms so that someone else can keep an eye on them as well. Also empower the patient to call their physicians for such things. Okay, in the end, let's just review some of the red flags that should trigger a quick decision and probably either a phone call to your physician right away or taking the patient to the ED. So among your history gathering and your exam, if you have someone who's complaining of chest pain that is not their usual angina chest pain, then this is a red flag. A very low blood pressure is a red flag. A very high blood pressure can also be a red flag, but that could also be something that the patient is just exercising and exerting and you just need to give them time to rest and reevaluate. But a low blood pressure, which is, and especially in a setting of symptoms of dizziness, is a concern and should prompt a quick decision. Dyspnea in a setting of fever may be an indication for pneumonia. Lastly, the red flag would be if someone has new or higher oxygen requirements from their baseline. So if the baseline requirement is 2 liters and now they're on 6 liters, this is a red flag. So again, these are your 5 red flags that you should keep in mind: chest pain, low blood pressure, dizziness, fever, and new or higher oxygen requirements. Now, other symptoms, they are by themselves not necessarily red flags, but depending on their severity can fall into this category where a quick decision needs to be made. For example, if someone is having very high heart rate or very low heart rate. Similarly, someone has gained too much weight and is symptomatic, and so on and so forth. But for the 5 red flags that should always trigger a quick decision and escalation, keep these ones in mind. With this, we have covered our objectives for this module. We hopefully have a mechanism in our minds that how to escalate and when to escalate. It is always safer to err on the side of talking to your physician and over communicating rather than under communicating. We should recognize that our pulmonary rehab facility is a healthcare facility, but it has very limited options for actions that we can take. We can only give them oxygen, maybe their rescue inhaler, and that's pretty much it. So if there is a issue going on with the patient that needs higher level of care, do not hesitate to escalate. At the same time, do not feel like you're alone in making this decision and contact your physician right away. And that's pretty much it. Thank you for listening.